Good afternoon and welcome to Bamboo Health's October webinar. Thank you for joining us. I'm Allison, Senior Communications Manager at Bamboo Health, and I'll be kicking things off for us today. But first, some housekeeping items. Participants are muted but are able to put questions in the chat. We'll answer any questions for our two presenters at the end of the webinar. If you have questions beyond what is covered, you are welcome to email solutions@bamboohealth.com and someone will follow up with you in the very near future. We launched the new company name Bamboo Health in August following Appriss Health's acquisition of Patient Ping earlier this year. Appriss Health was well known for delivering cloud-based care coordination software and analytic solutions focused on prescription drug monitoring and behavioral health and substance use disorder solutions. Patient Ping was known as a care collaboration platform that connected providers to seamlessly coordinate patient care in real time and collaborate on shared patients through a comprehensive suite of solutions. Now the two companies are bringing the best of both together as Bamboo Health. We provide one of the largest, most diverse care collaboration networks in the country. Our network enables providers to improve whole person care with a full view of their patient, including physical and behavioral health, all within the clinical workflow. The goal is to improve health outcomes and provide more efficient and effective use of resources. Together as one, we have this mission to enable our customers to optimize value-based outcomes by delivering information, actionable insights, and support for the delivery of whole person care through payer and provider collaboration. We're happy to have you here with us. Today, the focus of our webinar is on one of our prescription drug monitoring program or PDMP related solutions called NarxCare. NarxCare is a robust analytics tool that uses data from PDMPs and distills it for clinicians with interactive visualizations of prescription usage over the last 2 years, as well as patient risk scores to help clinicians make more informed prescribing decisions to prevent addiction and to determine when patients may need additional support. Within the last few weeks, a peer-reviewed publication about the scores within NarxCare was published in the journal Drug and Alcohol Dependence, and the lead investigator is our guest speaker today. First, a little background about our host, Dr. Krista Whalen. She is the lead data scientist for Bamboo Health's data science team. She graduated from Princeton University in 2008, then worked as a contractor for the Air Pollution and Respiratory Health branch of the CDC in Atlanta. While in Atlanta, she earned her MPH and doctorate in epidemiology from the Rollins School of Public Health at Emory University, focusing on dietary patterns and risk of chronic disease. Since joining Bamboo Health, she has focused on utilizing PDMP data to identify patients at risk of adverse opioid outcomes and evaluating program successes. Dr. Gerald Cochran is our guest speaker today, and he is an associate professor in the Department of Internal Medicine, Division of Epidemiology at the University of Utah, and serves as Director of Research for the program on addiction research, clinical care, knowledge, and advocacy within the Division of Epidemiology. He also has an adjunct associate professor appointment with the University of Utah Department of Psychiatry, and is core faculty with the Informatics, Decision Advancement, and Analytic Science Center of Innovation within the VA Salt Lake City Healthcare System. Dr. Cochran's area of expertise involves identifying and studying appropriate care for underserved populations in healthcare settings, with particular emphasis on individuals who use drugs and alcohol. He has extensive expertise in clinical and system-level behavioral health services research. His work has focused on development and testing of evidence-based practices for addressing opioid and other substance use in healthcare settings. Dr. Cochran's work aims to improve substance use prevention and treatment services. He earned his Ph.D. from the University of Texas at Austin School of Social Work and completed postdoctoral training with the Johns Hopkins School of Medicine, Department of Psychiatry and Behavioral Sciences. So welcome to both of them, and I am going to hand over the reins to Dr. Whalen.
Thank you, Allison. So I'm going to be really brief and just do a quick overview of NarxCare. So I know Allison already talked about it a little bit, but NarxCare is our analytics tool that sits on top of the controlled substance prescriptions in the PDMP, basically converting and summarizing the list of PDMP prescriptions that a patient's been filling into some overall assessment of how they've been filling. So while we've worked with several state agencies in the past to associate those risk scores based on prescribing metrics with unintentional overdose death, we're super excited to see outside research assessing these same scores in association with other clinical tools. So now I'm going to turn it over to Dr. Cochran to discuss his research and findings.
Thank you. And great. I'm assuming everybody can see my screen now. I'll
Yes,
go ahead
and just wanted to confirm for you.
No, you read my mind. Thank you. Great. All right. So very happy to be able to talk today about this project. And the title is the title of the project, or the presentation, is just the title of the paper that was published. So I'm just gonna jump right in here to these slides and start just working my way down. So just as a first point of information, just disclosures. I don't have any conflicts of interest to disclose, and this project, and I don't receive any support from Bamboo Health or APRIS or anything during this project or now. So as Dr. Whalen had said that this is, or Allison had said that this is a paper that came out. I have this little slide here that just basically says, don't take it from me. You can read this paper, all the stuff in this paper in the publication. It may not be free online through PubMed yet, but if you have institutional access, you should be able to get a complete copy of it. And as the paper goes through the process with PubMed, it will be freely available in its complete form there as well. So again, keep your eye out if you're interested. So just a bit of background about this project and this work generally. We really took this from the angle of community pharmacy. That's one of my big interests, is how to better integrate and work with community pharmacy in the continuum of healthcare for substance use, particularly opioid medication misuse, opioid use disorders. So within community pharmacies, oftentimes people refer to community pharmacies as like information deserts, because they're not oftentimes connected to health systems. So there's not a lot of patient information that is housed. And so one of the greatest resources available to the community pharmacist for tracking and understanding risk that a patient might have for regarding their opioid medication use is the prescription drug monitoring program. It really helps bridge this gap in information. That's great potential, and there has been there's increasing research showing that years ago there was some research saying, yeah, these prescription drug monitoring programs aren't, they're not really impactful. But as the research has gone on, more and more evidence is coming out as these programs get more sophisticated about the information and how it's presented and what kind of resources they provide to providers and prescribers. Like there have been detected changes in patient behaviors, which could potentially translate into improved health safety. As most people on this call, I'm guessing, know, Bamboo, APRIS, I'm going to probably mess that up consistently today, I'm sorry. Bamboo, their PDMP vendor for most states in the United States. They have developed, as Dr. Whalen said, this kind of suite of tools for prescribers and pharmacists dispensing. They have one of the risk metrics is called the narcotics score, and that's the one we got really interested in for this project, and that we focused this work on. What previous work that Dr. Whalen's team and others within the organization had done was what I'd call some preliminary validation work. They knew that this score is related to overdose, that higher scores, have stronger relationships with overdose mortality. We wanted to take the work a little bit further and look at more opioid risk behavior, like use disorder, misuse type constructs, and how the score was related to it, really for the idea of, maybe helping people more upfront in terms of potential health problems or substance use problems. So the aim of the paper, the paper reports on this primary aim of this project, and it was to validate the narcotics score metric with the WHO Assist, and using the WHO Assist as pretty much the gold standard metric. Lots and lots of research have used the WHO Assist for a variety of different drugs for kind of reference metric as new metrics or new scores or different assessments are developed, and do a validation there, but also, as many people know or may know on the call, the WHO has these risk thresholds, kind of the low, medium, and high risk thresholds, and we were interested in identifying where the cutoffs for the narcotics score would be on those risk thresholds, really with the idea of providing actionable clinical data. Because a lot of work has been done with the assist on what providers and healthcare providers should do, when patients have these different levels of risk. So we wanted to kind of merge that information with the narcotics score. So this was a cross-sectional, so the design of the study. Okay, so it's a cross-sectional. We collected prospective data from patients, which is in and of itself novel, having prospective data merged potentially with PDMP information. That's kind of novel by itself, and an important advancement in the field, and just a demonstration of the great partners that the Bamboo team have been. We implemented a prospective one-time survey in 19 pharmacies within Ohio and Indiana, community pharmacies from a large chain. Patients were informed when they came in to pick up their medication. They were informed about the survey from the pharmacy staff. If patients had a surrogate coming in to pick it up, there was a method that we had that the surrogate could take information and give it to the patient, and the patient could potentially complete the online the assessment remotely. Patients, once they, if they were interested in learning about the survey and opportunity, they were given they could be given an iPad in the pharmacy, or they could complete remotely an interest questionnaire. Completing the interest questionnaire, it automatically generated an e-consent to the patient to their email, and then they could, if they consented, if it's an oral consent, they could fill that, acknowledge that they wanted to participate, and then they went on to a screening, a self-screening. If they passed the screening, then they went on to complete the assessment. The participants in the study were 18 years old, spoke English. We asked them if they were receiving treatment for cancer. This is self-reported, and as many people know, opioid medication use. Oh, and excuse me, I should have said this up front. All patients who were offered the survey were people who were filling opioid medications in these pharmacy settings. That was kind of the thing that triggered staff to hand them the information, give them the information. And we know that opioid pain medication use for people who are actively receiving cancer versus other conditions may look different, so we did exclude those people. People who were only filling buprenorphine products were not included. This is because buprenorphine is provided for some formulations for pain, some for OUD treatment, and sometimes that's not super clear for you know, why the patient may be taking that. So those people were excluded. They could have only completed the survey one time, and we verified that. The study staff and local area confirmed that. And then the patient wasn't, if they acknowledged any sort of impending criminal justice involvement, we didn't enroll them just because we may not have been able to contact them afterwards. Everybody that participated got a $50 gift card. Well, completed the survey, got a $50 gift card. So a little bit about the narcotics score. It's a continuous indicator from 0 to 999. We'll spend a ton of time on what all those numbers mean, but it's essentially a composite indicator based on an algorithm that's been developed by Bamboo, and has 5 indicators that make it up: morphine equivalent, sedative usage, overlapping opioid prescriptions, and then, you know, numbers of prescribers and pharmacies. And those last two, oftentimes in the literature, is it's conceptualized as like pharmacy shopping or doctor shopping. So it kind of brings in, and as everybody is probably thinking, yeah, these are kind of the usual suspects for a lot of opioid-related risk research. So the instruments that we collected from patients, so the WHO Assist, it's developed by the World Health Organization. It has, it assesses a number of different drugs. And so the primary here was the prescription opioid use. We also asked people about their history of overdose, non-fatal overdose, obviously, from illicit drugs. Then we also asked participants about, we used the other WHO Assist subscales for non-opioid substances, marijuana, alcohol, cocaine, methamphetamine, et cetera, et cetera. We asked PHQ-2 about depression, a single item about general health from the short form 12. We also asked them about pain using the BPI, and then we had a number of demographics that were utilized or asked. So as you all might be thinking, you know, validation study of identifying cutoffs, the standard analyses here, ROC curves with AUCs using for the gold standard metric of the ANALYSES with the narcotic score and its relation to that score. For identifying the risk thresholds, kind of those cutoffs, we used a grid search validation machine learning approach. And then for the concurrent validity, kind of the relationship, just kind of the association between narcotic score and the prescription misuse score. We use a Spearman's and Cohen's kappa. And then all that was done in a validation, a training and a validation approach. So half the data was used as kind of in a training data set approach, and then we validated with the other half of the data. We reran the analyses for the primary analyses in the validation data set. Now, we did some exploratory analyses that I'll talk about obviously here in a few minutes, but we actually, for the exploratory stuff, we used a single data set. And for that, we just used some descriptive statistics and some basic regression analyses to explore false and negative cases. Okay, so who responded here? This is just a kind of a quick kind of schematic here. Most important thing is probably the last couple of boxes. We had a total of 1,523 people who completed the survey, and of those who had sufficient data in the PDMP program at the time, meaning they filled more than one prescription, 1,464 individuals had a narcotic score. So we had well over, for the statistics interested people, we had well over 80% power for all of our analyses in this. So a little bit more on who the sample was. You know, as we've been doing research in community pharmacies on prescription opioid medication misuse for kind of a long time, I guess maybe close to 10 years. It seems like most people filling opioid medications are around 50 years old. It's the average age usually. We usually have a little bit higher proportion of women. Just because it was in Ohio and Indiana, the sample is predominantly white. And if you read the paper, we kind of have a long discussion about doing this study other places where there's more diversity in terms of race, ethnicity, and geography also. So, but majority white in the sample, non-Hispanic white. So most participants, the largest share was married and then working, and then most everybody had insurance. In terms of behavioral health kind of background, and so about 10% of the population reported having some sort of overdose in their life on some sort of illicit substance, or illicit use of medications or something like that, which was very interesting finding for us. Most people, health was typically average, kind of their general health, well-being, typically average. Depression, about 20% of the sample reported enough symptoms to be screen positive for depression. And then pain was about average. That's on this pain severity was on a 10-point scale. So about average levels of pain, opioid medications are prescribed for the treatment of pain. So we didn't get a lot of, on average, pain was not uncontrolled. For what substances, when we asked them about drug use, and specifically about prescription opioids, this is, and just so I emphasize here, this is specifically about, the way the questions were asked is about non-prescribed use, like using outside of what the physician had prescribed. So you can see there, most people, there's quite a few people who came up as, kind of a moderate to and high with the prescription misuse. Other than that, we saw a little bit of cannabis use, about 10% of the population, about 15%, kind of this recreational sedative use, a lot of tobacco use, and approached about 10% of this risky alcohol use behavior, which is another really important point about which is another paper we're working on about alcohol and opioids together, which is a really interesting thing that we've seen consistently in our research over time. So looking at this ROC curve, you can see here these risk thresholds with the narcotic score, both the moderate risk level and the high risk level. Both those with the AUC values for those were over 0.7, which is fair level of agreement. It's not perfect, obviously. Nothing in life is perfect, obviously, but fair level of agreement, adequate, for performance there. In terms of the relationship, the Cohen's kappa was in the fair level again, similar level of strength of agreement, and then looking at the Spearman's correlation, significant association, as you might well guess. And this is just, kind of underscores some of the work that APRS did in their association work, or Bamboo did, and fair level or moderate level of agreement there. So next thing that was important, and so we recognize, so this is a good predictor, it's identifying people here, right? It's identifying people who have risk use, both moderate and high risk. So that's good, but we do know we had some false negative and false positive. So false positive cases would be individuals who the risk score is detecting, but when we ask them about their substance use, they're not reporting substance, like this kind of misuse or high risk prescription opioid use. And this is our exploratory analyses. Okay, so what are their characteristics? Who are these people that are in kind of this bucket? So these were people who had some sort of work status issue, including disability. So this was a kind of people who probably were not in the workforce because of a disability or something like that. They reported poor general health, and then they had increased levels of pain. So as I said earlier, or kind of across the sample, it was kind of average pain, but these people had increased levels of pain. So so uncontrolled pain. And these people were less likely to have substance use involvement. So this sample is probably a group of people who don't get a lot, their pain isn't being adequately managed right there. So that's important kind of clinically, right? The false negative people, the other group, these are the people who the score didn't pick up, but when we asked them about their substance use, they had substance use going on. And we did the regression here, and as you might as well guess, these people had significant histories of overdose, like 200% more likely had some sort of history of overdose. And then across many substances, lots of substance use there. So these are people who, the pain medication use isn't coming up on the algorithm, but there's other risk behaviors there that, and we wouldn't honestly expect the PDMP risk algorithm to pick up, kind of all this ancillary illicit use. But kind of the takeaway point is that, this is a fair tool for risk identification. In kind of how we said in the paper, it can be used as a universal tool, like it is being used as a universal tool for risk identification. Once people are identified on it, there should be additional steps that pharmacists and maybe prescribers, but particularly pharmacists, are taking in order to okay, I have a patient in front of me. This is their risk level. Therefore, here are some steps that I need to take. Clinical decision support would be really valuable, kind of as next steps for this line of research and testing that out. What's the right clinical decision support profile for these patients? And we obviously have ideas about what that looks like and how to design that. So putting that together as a study would be really a smart way to proceed. So with that, I'm about at my 20-minute mark here. So I'm just going to say thanks, and I'm going to give the control back to, or do I need to give the control back, Allison, right now? Stop sharing here.
It's up to you. You can actually keep it on that final slide if you'd like.
Okay.
But
all right, there it is. Great.
Perfect. So if anyone has any questions out there, you can add them in the chat or the questions panel, and I'm happy to read them to Dr. Cochran. We'll start off while people are thinking, and I have one. We hear the word risk a lot, and I guess sometimes that feels like it has a lot of weight, but when we're talking about narcotic scores and even the WHO's screen assessment, what really are we talking about when we say risk?
Yeah, great question. Often, in terms of the assist, right, there's low, medium, and high. And how I like to think about it in simple terms is the low are people who, are using, the opioid medications. Everybody in the study obviously is using opioid medications, but nothing in their behavior would indicate a potential problem. The moderate level, I think I kind of equate in my mind as a non-medical use or misuse. In our other research kind of claims data stuff, we've modeled kind of concepts of misuse, and people who are engaged in misuse, this is kind of that trajectory to opioid use disorder potentially. Our specific research has shown like maybe a 200% increase in risk for overdose eventually in some populations for those who are engaged in misuse. And misuse is things like, again, like non-medical use, like early refills, doctor shopping, using the medication to treat, kind of deal with personal problems, using more of the medication than prescribed, kind of combinations of those kind of behaviors. Now, high risk on the WHO assist specifically, I think of as probably indicative of opioid use disorder. And this is when we're moved in kind of that DSM world. And those behaviors are probably correlated with things like, I'm having personal problems, I'm having kind of withdrawal symptoms. I'm having kind of trying to cut down, I'm not able to, kind of that standard DSM criteria is what I kind of equate it to in my mind for kind of those three. Kind of, anyway, for that high risk, and then, so that's what the WHO is referring to. So now, clinicians potentially, or pharmacists, now that, if they have this paper, or, if APRA or Bamboo, is incorporating these scores, I can, oh, my patient's in this high risk range, oh, opioid use disorder, gotcha. Or potential opioid use disorder. Okay, what steps should I take? Okay, we need more assessment. We need potential referral to treatment, right? Do we need Do we need to connect this patient back to primary care immediately, kind of thing? At moderate level, we can think, oh man, this is somebody who might be messing around a little bit. You're not being really adherent to their medication. Do I ensure that this person leaves with Narcan? I mean, everybody should leave with Narcan when they have an opioid, but make sure that they have Narcan. Have maybe, in my view, those moderate risk patients are primed for brief conversations with a pharmacist and a patient about, like a brief intervention type thing, like, exploring what's going on and potentially talking to the patient about options. Anyway, long answer, but that's what I was thinking there.
No, that was perfect. One question that came in is, were other scores evaluated or just the narcotic score?
Yeah, so we did, Bamboo, they did share with us some of their other scores, but we haven't done any work with those. Like, they have a couple of versions of the overdose risk score, but the primary aim of this study was the narcotic score. So maybe someday we'll do a secondary analysis, and maybe Bamboo will want to partner with us, or NIDA will want to do other work, and we can validate those scores as well. Because the data set is there, the scores are linked. We haven't done anything else with kind of the other scores in the suite.
Another question that came in is, are there any plans to validate this tool in other populations? And this might be a question for both you and Dr. Whalen.
I'd love to do that. Dr. Whalen, I bet we could tag up for that if we got some more. If we could get some more funding, we could definitely do that work.
Yeah, I'm always interested in looking for additional validation data sets. Wherever we can test this against real world data, it would be wonderful. So whether or not Jerry has the bandwidth, or if somebody else on the call, we're always open to that.
Yeah, great. Yeah, and if the person who asked the question is interested, I think that is literally one of the recommendations in the paper, that next things that need to happen. So love to partner with people if they're interested in that idea.
And then another question was, is there any research planned to examine how the tool predicts actual outcomes, as in opioid-related adverse events or overdose?
That's kind of, I think APRIS has done some of that work already. When they first developed the score, they have like this really nice white paper. But it would be really cool someday to actually take our patient-reported data, their risk scores, PDMP data, and link it up with like a health system. And we could get some poisoning information in there, some overdose information. That would be just a great, really very, very valuable contribution to the literature. Anyway, sorry, Dr. Whalen, you were going to say something, I think.
No, I think that's exactly right. I would love to do more associations with more adverse event outcomes. It's just a matter of finding the right partner who has those specific outcomes.
It is a little bit tricky, and I'm not speaking for Bamboo or anything, but in our experience, it is tricky because it's, states own this data, and so it just takes a lot of time. When Dr. Whalen said the right partner, these projects, there's the research, but then there's logistical and regulatory stuff that really takes a lot of time to get everybody to agree, and permissions and things like that. So it's not for the faint heart.
So I guess related to that is, do you have any current research plans in the future to build off of what you've learned in this study, or still looking for the right partners, as we've kind of been talking about?
No, that's awesome. Yeah, we have a proposal that we have put together through the same funding source here, and same partners are all in place. Just a great, really collaborative group of individuals from the pharmacy side. The state has been just very kind and generous and then some the professional organizations that are involved. So we do have a proposal. If that doesn't, get picked up kind of for the phase 2 of this from the funder, I've been kicking around in my head, how can we, take it to another funding source to take this kind of to the next level to do this. And I think what's important about this work, and I said this at the beginning, is this, Bamboo is a really big company, and they cover a lot of places in the country. But this is they aren't driving the bus on this. I mean, this is their stuff, but we're trying to. This is like an independent kind of thing that we've done. So it's not, they're not paying for this work. So we are kind of subject to finding, outside external. And again, I'm not paying for this work. We're finding external funders who see it, what a big impact this can have on patient safety and health, and supporting the work that way. So it's just a little challenging there, but we're trying. We're trying to take it to the next level.
Great. Well, I don't see any additional questions, but as I noted at the beginning of the presentation, if you think of more questions from here, you're welcome to reach out via email to solutions@bamboohealth.com. And if it's a question specifically for Dr. Cochran, we'll be happy to forward it his way and hopefully get you the answer that you need. So thanks to everyone for attending, and you will also get an emailed recording of this later in case it prompts additional questions. But thank you so much for coming, and have a great afternoon, everyone.